Hi, my name is Dr. Karen Semmens. I am part of the Dakota Geriatrics Workforce Enhancement Program. Along with Dr. Chris Hendricks, we have developed a series of lectures on the age-friendly concept of the 4Ms. The 4Ms are mind, medication, mobility, and what matters. This presentation is focused on the mind. The name of this presentation is Geriatric Depression. Some of the objectives that we'll be trying to reach during this presentation are to recognize the risk factors for geriatric depression, identify the signs and symptoms of geriatric depression, understand the types of assessments used for geriatric depression, and identify the treatment options that are available. The incidence of geriatric depression is in 2020, 21 million adults in the United States had at least one major depressive episode. 16% of those were 55 to 59 years of age, 14% of those were 65 to 69 years of age, and 14% of those were 85 years or older. The incidence of major depression is higher among women than men, and that could be two major reasons is hormonal, and women tend to live longer than men. It is important to note that depression is not a normal part of aging. Even if the person is having what we might call situational depression, when the spouse dies or a loved one passes away, it is not normal to go through a depression. Geriatric risk factors. Some of the medical conditions that can cause an underlying or a depression can be any underlying chronic medical condition, such as diabetes mellitus, Parkinson's, arthritis, low vision, chronic obstructive pulmonary disease, or COPD. Other things can be some vascular type diseases, such as having a heart attack, an MI, a coronary artery disease, or CVA, which is a cerebral vascular accident, or a stroke. Any one of these chronic medical conditions can cause the person to have difficulty with their activities of daily living. Bathing, dressing, and grooming is what we're talking about for those. The instrumental activities of daily living, such as being able to write a check, balance your checkbook, fill your own medications, being able to drive from one place to another. All of those things can be affected by chronic medical conditions. That can cause some depression because you're no longer able to function independently. You might need some assistance. Pain is also a risk factor for depression. Insomnia, not being able to sleep, and many of our elders do have difficulty with insomnia. Any diagnosis of prior depression when they were younger can be a risk factor. And if the person does have some dementia, there is a depression that does kind of go hand in hand with some types of dementia. If the person has some personality attributes, such as maybe they have a personality disorder, or they have low self-efficacy or low self-esteem, they just don't feel good about themselves, they haven't felt good about themselves for many years, and they can slide into a depression. Life stressors, such as trauma, low income, impaired function, and disability can also be risk factors for geriatric depression. Social stressors, and we talked a little bit about bereavement. There is going to be some, depression and feelings of sorrow and loneliness when someone does pass away. However, moving from that situational type depression into a major depression, it does need to be taken care of. If the person has impaired social support, if they are doing some caregiving, caregivers can suffer from many different types of symptoms, but depression can be one of them. This is not how you expected to retire with your loved one. Maybe you wanted to travel, but now your spouse has had a stroke, and now you're having to do caregiving versus the things that you had planned to do. Lack of physical activity. You're just not getting outside, you're just not moving around, you're starting to feel maybe more of the pain, just the loss of independence because of the lack or loss of physical activity. Certain medications can be a risk factor, and substance abuse can cause depression. Some of the signs and symptoms that we want to look for someone who's having some depression that we might be thinking about is we talked about some of these. The insomnia, not being able to sleep, staying awake at night worrying about things, and insomnia can lead to fatigue. Cognitive deficits. If you're having problems sleeping, you might be having some problems with your cognition, your ability to remember things. But having a memory impairment can also be something we want to look for. anorexia, which could lead to weight loss, constipation, lack of interest in activities previously enjoyed, and a decreased interest in sex. Many times we might find that an elderly person is misdiagnosed and is not assessed for depression, because if you look at these signs and symptoms, some of this can be considered normal aging. Elderly people don't sleep as long as they used to. They may not get the 8 hours of sleep like they used to, and they might sleep in little blocks of time. Not having a good appetite anymore because you lose that sense of taste. Constipation is common in the elderly. So even though the person has some of these and you might think it's normal aging, you need to go a step farther and start asking some questions. Do they have some depression? Do they have expressions of self-deprecation? Or they just really don't feel good about themselves? They feel guilt. They just feel apathy. They don't want to do anything anymore. They feel remorse that, maybe somebody has passed away and they never got a chance to say they love them, or they never got a chance to say they were sorry. A feeling of helplessness. And many of our elders feel like they're being a burden, especially if they do need some help with their cares. And that whole feeling of loss of independence can be something that we got to keep an eye on. So to assess a person for depression, there's kind of two main types. One is called the PHQ-2 or the PHQ-9. And it's the same test, only the PHQ has 2 questions and the PHQ-9 has 9 questions. The 9-question PHQ includes those 2 questions from the PHQ-2. So the PHQ-2 screens for depression. The PHQ-9 determines if the person meets the criteria for a diagnosis of depression. So then there's an example of this in the next couple slides. So the PHQ-2, if they answer questions not at all to the first 2 questions, then you would ask the rest of the questions on that form. The Geriatric Depression Scale, there's 2 different types of those, the long version and the short version. And we'll show you an example of each of those. So here are the 2 questions that would be on the PHQ-2. Over the last 2 weeks, how often have you been bothered by the following problems? Nearly every day, more than half the days, several days, not at all. Little interest or pleasure in doing things, feeling down, depressed, or hopeless. If you answer these questions and the provider says, I think maybe we should move on to the PHQ-9, you use these 2 questions and you move to the next 7 questions. So if the score is greater than the if the score is 3 or greater of these questions, so if you have answered more than half the days for both of these questions, that's going to be a score of 4. If you've answered, more than half the days for one and several days for the other, that's a score of 3. You're going to move on to the next 7 questions. And these are the next 7 questions that would be on the PHQ-9. PHQ stands for Patient Health Questionnaire. Okay, this is how they assess. So when the provider is doing the PHQ-2, this will tell you them which category of depression they have. Is it 1 to 4? Is none? As far as depression severity, and then it goes down to if the score is greater than 15, they have a major depressive disorder. Then you need to start thinking about maybe doing some type of treatment. So even in the mild to moderate, to do some further assessments. And here's what the Geriatric Depression Scale, the short form, looks like. And I don't have to read all of these for you. But a score of 5 or greater is suggestive of depression. A score of 10 or greater is almost always indicative of some type of depression. A score of 5 should warrant a follow-up comprehensive assessment. Okay. Severe depression, suicide risk. It is not uncommon for a geriatric person to have some severe depression and think about suicide. Untreated depression can lead to suicide. And interestingly, I don't know if it's really interesting or it's surprising, that suicide for the elderly is higher than any other age group. Men over 85 have the highest rate. And suicide attempts of those elderly are more likely to result in death. A more violent type of suicide, gunshots, car accidents, those types of very kind of violent type attempts. Women tend to do more of the medication overdose. So some of the risk factors are social isolation. So men having the highest rate. If you think about, they've been married for many years, the wife passes away, their significant other passes away, they don't have that companionship anymore. They maybe they don't have hobbies or anything to keep them occupied. I'm just thinking about my father-in-law. When his wife died 6 months later, he passed away shortly after, which we were expecting, and he did have some depression. His wife always did cook the meals. It was his best friend. He was kind of sad. We moved him into an assisted living, and his daughter was very excited because she said, Dad, look at all the things you can do here in this assisted living. They have pool. You can, play pool with some of the other guys or ladies. They have card games and things like that. And he pulled me aside and he said, Karen, he said, Lois, which was his wife, Lois was my best friend. We did everything together. I don't know how to make friends. And he was in his upper 80s. And I thought, wow, that is really significant. For 60 some years, he was together with his wife. They did everything together. They shopped together. They traveled together. And he said he didn't need to make any friends because he had her, plus some of his other friends had passed away. And he didn't know how to go out and play cards with the others or play pool with the others because he said, I don't know them. What if I'm not playing right? What if they don't enjoy my company? That was pretty significant to think, wow, he is depressed. Some other risk factors, again, alcohol and drug abuse, the physical illness that we talked about, and again, any underlying mental illness. Another surprising statistic is that 58% of the elderly who commit suicide have seen their provider within the last month. That should indicate that we do need to be doing some assessments. We do need to do that geriatric depression scale. Ask those 2 questions on that PHQ-2 to see, do they have some depression that's brewing. Many times they try to mask it, that there's nothing wrong, I feel fine. Some of the interventions, we would want to encourage expression of feelings. Listen to them when they're talking. Don't minimize their feelings. Don't brush it off as, well, your wife just passed away. Of course you're going to feel depressed. No, not really, not always. Take the suicide threats seriously and discuss them. It is okay to say to them, you sound like you're thinking of taking your own life. Are you thinking about that? Do you have a plan? And if you have a plan, what is it? Offer hope. Provide for their needs. Are they getting enough nutrition? Do they need some help with cooking? Do they need some help with cleaning? What's their activity level? And what is their sleep? So sometimes we talk about these as being their vegetative symptoms. Are they tired? Are they don't have any energy? And are they sleeping okay? Are they eating too much and they're not eating enough? So checking out those 3 things. Some of the non-pharmacological and pharmacological interventions. Non-pharmacological psychotherapy, which is basically talk therapy, having them go to see a psychiatrist or a psychologist or a licensed social worker. They can help with the psychotherapy. If you have somebody who has major depression, you should start the psychotherapy at the same time as you do an antidepressant, because it takes a while for the antidepressants to work, especially in an elderly, because you want to go slow with the medications, and it takes time to reach that therapeutic level with that medication. So as the medication starts to work, and sometimes it takes 6 to 8 weeks for that medication to kick in until they start feeling better. So if they're doing some talk therapy at the same time, they can be working through some of those issues while they're waiting for that medication to start working. Some family support. And, what is their support group? Do they have good family support? Do they have some good friends? And is there a support group that they'd be interested in? Is there like a grief group? That would be something that they need to work through. Some of the pharmacological agents would be antidepressants. And the elderly person, they usually like to start with the SSRIs, or what is known as a selective serotonin reuptake inhibitor. 2 medications that are pretty common, commonly known, I should say, are Zoloft and Prozac. And then there's another medication called Remeron that is works well with the elderly. The reason they pick these, the SSRIs and then Remeron, is because they're pretty well tolerated for the elderly. The type and dosage depends on the severity of the depression, and that's going to be up to the provider to decide which medication would they like to use. Excuse me. So here's a case study. Ellen, a 69-year-old, has come in to see her primary care provider for a follow-up for her minor surgery she had a month ago, where they removed a non-cancerous skin type. Excuse me. Upon routine assessment of Ellen, it was noted that she had lost 15 pounds since her last visit a month ago. When asked if she was planning on losing weight, she states that she's not sleeping, has no appetite, and doesn't have any desire to go to her weekly book club meeting. So if we go back to some of our risk factors, she has those three things. She's not eating very well, her appetite has changed, she's lost some weight, she's not sleeping, and her activity level has decreased. Ellen appears teary-eyed, and when you ask what was wrong, she responded that her husband of 42 years recently passed away. So she has some new grief. So what questions would we ask Ellen? Well, we would ask her, what is she eating? How much is she sleeping? What's going on with her? Ask her if what's her support system? Does she have someone that she could go visit with? Is there a grief support group? Does she have anything? And if she's a religious person, does she have a religious person, spiritual advisor she could talk to? Is it okay to ask her if she has feelings of hurting herself? Yes, absolutely. People will say, well, if you ask, someone if they're planning on hurting themselves, then you've planted the idea. And no, it's actually the opposite. The idea is already there. Ask her what her thinking is. Does she have that feeling of harming herself? Does she feel helpless? Does she feel hopeless? How can we help her? So what assessment should we do? We should do the PHQ-2 and find out if she scores over 3. If she scores over 3, we would do the PHQ-9. What would be a good intervention to start right away for her would be the psychotherapy. Trying to find a support group for her. Trying to get her in to see someone. It's not a bad idea to have somebody call her the next day and say, I was just wondering how you're doing. Setting her up with, maybe Meals on Wheels. Meals on Wheels is a great way to have someone checking on her every day. So, okay. These are references for this presentation, and we appreciate your attendance, and thank you very much.